Good afternoon, everybody. My name is Rachel Weisbrod. I lead clinical affairs at Medasense. I'm delighted to welcome you to the second in our series of NOL Explore webinars this afternoon. Thank you for taking time out of your busy schedules, and we hope that we have an exciting lecture for you. Today, we'll be focusing on the clinical implementation of NOL monitoring in routine practice in colorectal surgery and how this fits well into an ERAS protocol approach. We'll be considering the pharmacological reasons driving the need for personalized anesthesia, the challenges associated with managing a complex colorectal case, and the clinical reasoning algorithms that are guiding the use of NOL in combination with other monitoring technologies. So, introducing new medical technology is a classic example of change management in clinical practice. No patient monitor, as good as it may be, as good as the technology is, will improve patient outcomes by itself. Achieving consistent improvement depends on a close collaboration, on deep clinical implementation and adoption by the team. Today, we'll hear more about how NOL monitoring was integrated into routine practice at Bichat Hospital, and it helps enhance patient outcomes. And it also helps improve the collaboration between the anesthesiologists and the other members of the surgical team to the benefit of patients. So I'm delighted to introduce our speaker, Professor Dan Longrois. He is a professor of anesthesiology and critical care, intensive care medicine at Bichat Hospital in Paris. We'll start with a short audience poll on current anesthesia practices in colorectal surgery, and we'll be showing the results later on. So please feel free to send us any questions on the Zoom chat or Q&A channel. We'll be monitoring those questions. And at the end of the session, we'll have 15 minutes for a Q&A session. So without further ado, Professor Longrois, over to you.
Thank you very much, ladies and gentlemen. I'm happy. I will introduce myself a little bit later once the poll is displayed. So if I could have the poll, and the poll is intended to actually ask you participate to what is going to be the object of the presentation and hopefully the debate. So what you ask here is to choose the top 2 goals that you define in colorectal surgery in general. So the first is avoidance of intra-anesthetic arterial hypotension. The second is as low as possible post-op pain intensity and duration. The third is fast bowel function recovery. The fourth is decreased post-op pulmonary complications. And the fifth is shortened post-operative length of stay. So you see, it's a mix of clinically patient-oriented and institution-oriented goals, and you have to define the 2 most important for you. So take a few moments to vote. And if I can have the second poll. I think we can go to the second set of questions, the poll number 2, please. So the question now concerns the way as routine clinical practice, you manage this issue of balance between nociception and anti-nociception. And you can choose multiple answers. So heart rate changes, arterial blood pressure changes, the patient movement, cortical EEG-based monitor, such as the BIS monitor, or a dedicated nociception, anti-nociception balance monitor. So you're supposed to actually answer by sincerely, quote unquote, saying what you are doing routinely. We'll take a few more moments. Okay. Thank you very much. So I will take the lead as soon as Joella allows me to share my screen. And this is the poll number 3. So what worries you most? It's only one single answer. insufficient anti-nociception during anesthesia and surgery, excessive anti-nociception with the risk of atrial tachycardia or hypertension, cortical EEG activation in case of insufficient anti-nociception with the risk of explicit awareness or patient movement and the surgeon's reactions, or patient experiencing excessive pain after anesthesia and surgery. So it's only one single answer to see what is your main concern. So the question number 2. Okay, sorry. So as soon as, so I will actually now share my screen and basically go at the beginning of the presentation. Sorry. So this is the topic of this presentation. So I will attempt to share with you more than 1 year of clinical experience routine outside of clinical studies of the use of NOL in digestive and colorectal surgery. I work in Bichat, so I've been collaborating with all the major manufacturers of the EEG depth of anesthesia monitors, and also with those who look at the dedicated monitors of the balance between nociception and anti-nociception. And my academic credo is on the necessity of improving clinical reasoning. So complex patients need complex solutions. Of course, this is based on the guidelines and the knowledge that is accumulated, but also on the decision-making process for individual patients and specific situations. And this requires clinical reasoning in monitoring, and also it requires management of uncertainty. And I will attempt to insist on this. So the goals of this presentation is to build for you very shortly a conceptual framework and pharmacology and hypnotic opioids interactions, and uncertainty about what is adequate or good anesthesia for a given patient. A short presentation of the NOL monitor for those of you who have never used it or never seen it, and then put in parallel some of the knowledge accumulated on the monitors of nociception, anti-nociception balance, and then the tools which allow us to take decisions for a single patient, and then an example, a case scenario of NOL use in a patient who underwent colorectal surgery. So the conceptual framework, basically one needs to define nociception as a neural process that encodes the noxious stimuli and triggers autonomic or behavioral responses, such as elevation of blood pressure, motor withdrawal reflexes. And the questions to which we do not have definite answers is whether the body encodes differently a constant level of nociception or changes in the level of nociception. And you'll see whether this is important or not. And when this nociception and anti-nociception are balanced, well, there's lack of encoding and therefore lack of an autonomic and behavioral responsive. So nearly all nociception, anti-nociception monitoring is based on this equilibrium between the sympathetic and the parasympathetic nervous system, and looking at different sides of the body. And I think this issue becomes even more interesting with the opioids-free or opioid-sparing anesthesia regimens, because we do not have the pharmacological knowledge that we have with hypnotic opioid interactions. So I think it becomes absolutely mandatory to have tools that look at the nociception, anti-nociception balance with opioid-free anesthetic regimens. So the second part of the conceptual framework is that anesthesia is defined as a process, but in my mind, it is much easier to define it as a pharmacological relationship. So in this pharmacological relationship, we have the anesthetic drugs, either the doses, or it is easier to look at the predicted effect site concentration. And then on the other side, we have the effects. So you look at clinical effects, it's loss of verbal response or return of verbal response, the reflexes, the movements. I put the hemodynamic into the clinical, and then you have the infraclinical. So it's EEG, the equilibrium between sympathetic and parasympathetic nervous system, many others that probably will come. And then you can actually have a pharmacology which is calibrated. So if you know what is the concentration of propofol predicted at the effect site at the loss of the response to verbal command, then it becomes not only a pharmacological information, but it becomes a calibrated, clinically calibrated pharmacological information. And my credo is that given the complexity of anesthesia and given the complexity of the instability of the level of the nociceptive stimulation, then you need multimodal monitoring. And it's not interesting to oppose heart rate to blood pressure or to the BIS or to whatever, but you need to combine them. And basically, you have to take into account when you look at the effects, the interaction between hypnotics and opioids, and you also need to look at the perceived, at the cortical or neural system, the perceived level of stimulation. And this allows you to look at local regional anesthesia, at opioid-free cocktails, or opioid sparing. So basically, in this framework, you can introduce all the elements that constitute the anesthetic process. So, well, there are challenges when looking at the opioid dosing. The first challenge is that very, very high interpatient variability. And if you give a fixed dose in microgram per kilogram, it will result into very, very different concentration and responses in a given patient. So microgram per kilogram is better than nothing, but clearly it is insufficient. And this is the opioid interaction curve, which is called the isobologram, which is basically tells us that the interaction between the hypnotics and opioids are synergistic. So 1 and 1 are more than 2. And there's an optimum when you look at such interactions. And basically there's an optimum combination of hypnotic and opioids. But what this isobologram tells us is that if you want to avoid patient movement in a non-paralyzed patient, basically you have access to a very, very wide range of combinations. A little bit more hypnotic and a little bit less opioid, or the other way around. And this is very interesting. Now this isobologram, the closer this inflection point is to 0, the more synergistic the interaction is. And therefore you can decide to titrate the components both together and individually, okay? And of course, opioid tolerance has become an issue because many patients have cancer, they also have chronic opioid treatment, and therefore this increases the interpatient variability. Now, what I would like to draw your attention to is that in the previous curve, you've seen the typical hypnotic opioid interaction upon intubation. But now look at this in the middle. This is the hypnotic opioid interaction during maintenance. So the synergy, I told you, the closer to 0, the more synergistic the interaction is. So during maintenance, the synergy is even more important. So whatever information you can derive during the induction phase, so let's say you titrate to the opioid to avoid an increase in the EEG activation and the lack of increase in the BIS value, but it doesn't apply to the maintenance. So basically the use of the monitors cannot be limited to the induction, but it has to do with the maintenance. And the emergent is slightly different, but we already know this. So it's during the maintenance probably that hypotension is probably more prevalent than during induction because of things that we understand, and also because there's very different and more synergy between opioids and hypnotics during the maintenance. And the last part of this conceptual framework is that unresponsiveness is different from unconsciousness. We imagine that if a patient moves, he or she becomes conscious. This is totally wrong. So one can be responsive and still be unconscious. And because this difference between unresponsiveness and unconsciousness, it becomes mandatory to look differently at the monitors. And so you can not use only a monitor that look at unconsciousness. You also have to look at monitors that look at responsiveness, and the monitors that look at the nociception, anti-nociception balance actually allow us to have a window on this unresponsiveness. So the NOL, actually comes as a response, the NOL monitor, of a clinical need to be able to not look at nociception, anti-nociception balance only with heart rate and blood pressure, because they're neither sensitive nor specific. And this has been shown, I mean, regularly. All nociception, anti-nociception balance monitors do this, and NOL probably has the best sensitivity and specificity to be able to detect a lack of anti-nociception given a nociceptive stimulus. So basically, it allows us to look specifically at this nociception, anti-nociception balance, because if there's an imbalance between nociception and anti-nociception, you will have an activation of a sympathetic nervous system, and you can read it differently. And given this complexity of encoding of nociception, called here pain, because this is still a term that we use regularly, one needs to look at multivariate signals to be able to detect reliably this imbalance between nociception and the anti-nociception. So the multivariable approaches appear to be superior, and I'm convinced this is the case. And this is what the monitor looks like. You can have here on the display in the left upper corner of the monitor either two signals, conductance and the plethysmographic wave, or you can have the four signals with accelerometry. I usually use the four of them and the temperature. And then you have a number which indicates you what is the level of the nociception, anti-nociception balance, and then a color code. And then you have the tracing of the trends. And it is non-invasive. It is simple finger probe. It takes you 15 seconds to put this into in place. It's not difficult at all. It can be used routinely, and there's a scale. Basically, 0 upon nociceptive stimulus is no response, so there's no encoding of nociception. 100 is the extreme opposite, that is, you have a very, very high encoding of nociception. It's based on artificial intelligence, this scale. And basically, you have 3 codes here. The first one is in green, which is illustrated here. The nociception is in between 0 and 25, so that this represents that you have found the equilibrium between nociception and the anti-nociception. In red, you are in disequilibrium and anti-nociception is lacking, given the intensity of the nociceptive stimulus. And at times, you have very, very low, below 10 values of the NOL. And then in this case, and I will exemplify this, you need to take this into consideration. So it's not trivial. 0 can be problematic in some situations, and you need to know that this occurs. So there's a lot of information now in the literature showing that there is clinical value, and not only information and numbers and trends. So there's less post-op value when post-op pain, when NOL monitor is used. It reduces the stress hormone response. There's no doubt about this. What is, in my eyes, the most interesting part, and I will give you an example, is that it allows us to personalize the opioid dosing. And this is still an important problem. And by personalizing, you can avoid both overdosing and underdosing of the opioids. It allows us to confirm in a patient who already sleeps the effectiveness of regional analgesia, or if you're using the epidural, it also allows you to check its effectiveness. Safer analgesia in high-risk patients. It will also be an example, because you would like not only to avoid lack of opioids, but also to be sure that you're not excessive dosing the patient. And then, of course, this is, I would say, mandatory. If you're using cocktails which go out of the classic hypnotic opioid interactions and you're using the opioid-free regimens, then it becomes absolutely mandatory to be able to read the effectiveness of the cocktails that you are using. Just to illustrate here what is interpatient variability. So this is a fairly low number of patients. They are given plasma alfentanil, then they get the stimulus, and basically what you look is the probability of response. It could be movement. So you have here the effective dose 50, Or you can have this, and the effective dose 50 is a statistical approach, or you can have actually a personalized approach in which you look at the differences between the patient who is most sensitive to alfentanil and the patient who is the most resistant. And if in a low number of patients you compare what is the difference between the most sensitive and the most resistant, it goes from 1 to 5. And this is much, much higher than what we do with the effective dose 50 or effective dose 95. And this is exactly in what my mind is the most important part of such monitoring, is personalizing, individualizing dosing, because the differences between patients is so high that without monitors you cannot reliably detect such interpatient variability. So this is in my mind a very important issue. Now the problem is if you go beyond this personalized dosing, then of course you can segment the interest of the NOL, and it can be abdominal, orthopedic, spine, thoracic, because each surgical specialty has its own challenges. But in my mind, beyond everything, which is applied universally, is this very high interpatient variability. So of course you have procedures which are supposed to be painful. Thoracic surgery, open thoracic surgery can be of course very painful. Orthopedic surgery can be very, very painful, and lengthy and complex surgery, of course, whatever the specialty, can also be very interesting, and the NOL becomes informative. So the question now is, how do we put together the information provided by so many monitors? So this is a case report done on June 3rd, 50 years old male, 66 kilograms, 168. He was diagnosed with colorectal cancer several months before, got a colostomy in December 2020. The ecography had showed echocardiography, mild left ventricular and right ventricular dysfunction without obvious etiology. Basically, the chemotherapy regimen he got, Shunada explained this. So the challenges was intraop hemodynamic stability, avoid arterial hypotension, and then individualized anesthetic drug requirements, both on the hypnotics and the opioids. And then we decided to provide adequate post-op analgesia. He had a thoracic epidural successfully inserted, tested, and used only for analgesia after recovery and emergence from anesthesia. Just to show you, so this is we decided to put the novel monitor from Edwards, which allows you to estimate the stroke volume variation. And this is interesting because this monitor now has the hypotension prediction index, which went quite high without having a stroke volume variation related to preload dependency. And basically this patient raised many problems because he had mild left ventricular and also right ventricular dysfunction, shown here by DPDT. So this is a complex case in which hemodynamics is slightly unstable, being managed by us, and in which you want to know exactly where you are in terms of anti-nociception and also in terms of depth of anesthesia. So the patient received propofol, lidocaine, 0.5 milligram per kilogram of ketamine and sufentanil, and he was maintained with sufentanil, atracurum, and sevoflurane. And this is what happens because the patient got ketamine, and well, it's ketamine bolus at 0.5 milligram per kilogram will activate the EEG, and if it activates the EEG, we see it here, the raw EEG has quite a high frequency, and the BIS here goes up. So it's not that the patient wakes up, is insufficiently anesthetized, it is that the ketamine activated the EEG, so it becomes a little bit unstable. It takes about 15 to 20 minutes, and you need to look at this information and integrate it into your clinical reasoning. Now, what happened here is, so the patient was induced, the NOL value prior to induction, well, it can be the patient was not painful, but you cannot interpret this information reliably. So after 15 micrograms of propofol, this is a predicted sufentanil concentration of 0.3. So it's at the optimum point of the interaction between sufentanil and the propofol that we gave. The NOL was quite low. So you cannot really say for such a short period of time that you are being overdosed, but it told us, of course, the tracheal intubation went on, and the 15 micrograms of sufentanil that the patient received actually resulted initially into a very low NOL value. So the problem is that the patient was intubated with a video laryngoscope, and it took only 15 seconds to get the tracheal tube into the trachea. And basically the question here is, what can you draw as conclusions? Well, because it was video laryngoscopy, it's not direct laryngoscopy, and therefore that means that 15 micrograms of sufentanil was sufficient to avoid an increase in NOL with an nociceptive stimulus that is video laryngoscopy. Probably it could have been insufficient if a direct laryngoscopy could have been or had been done. So you need to know, when you interpret the NOL value, exactly what was the level of the nociceptive stimulation that is being done. So you cannot interpret the NOL value without having an information of the level of nociceptive stimulation. And then this is what happened. The NOL stayed low for quite a period of time. And then the patient was mobilized on the table so that he was prepared for celeoscopy. And now the question, would you react to this? Well, once again, clinical reasoning, if you only look at the monitor, because it was higher than 25, you could have said, okay, I will do something. I will do something. We didn't do anything because we considered, because of the map was stable, the heart rate was stable, the BIS was unchanged, that this was probably transient. And even if that level of stimulation is not nociceptive, but it's still stimulation, given the short duration, we decided not to do anything. Just once again to tell you that you need to interpret things into their context. Now, we had a problem with the signal that was foul. It was because of the arm which was compressed, was near to the body. And then the patient had laparotomy because the celeoscopy was going not sufficiently well according to the surgeon. And then we had the signal. So we had the signal about the laparotomy. And then the laparotomy had to be extended. And then when they extended the laparotomy, we gave 10 micrograms of sufentanil based on the information that the initial laparotomy triggered an increase in NOL. And then the second increase in NOL was much, much lower, of course. Now, this approach is reactive. It's not really proactive, but this is the way it is done. So we chose in this case not to use TCI, target control infusion remifentanil, because each time I present the case with the target control infusion, the question comes, what if I use bolus sufentanil or bolus fentanyl? So I think you need to do cases with both ways of giving opioids, both sophisticated and the more routine use of the bolus of sufentanil or fentanyl. So basically the information we got here, we took it here. Now you can ask me, why didn't you use more sufentanil following your first increase in NOL? And the question is, the answer to this question is, the question is relevant, of course, is we were afraid of hemodynamic instability. So the choice we made is to be sufficiently high in opioid dosing to avoid long duration increases in NOLs, but to be sufficiently low in sufentanil to avoid hypotension if there's no nociceptive stimulation. And this is actually continued. And it took quite a long time because now we're well advanced into the procedure. So the choices we made were quite useful. The sufentanil was stopped. So I avoided to use several infusions, but the patient got 80 micrograms for about 7 hours of surgery. So it's neither much nor a small dose, but basically we were right, and you will see how we were right. When we started preparing the emergence, okay, the patient had this increase in NOL. Basically, the choice was to inject morphine, 10 milligram, and it looked to us that the patient still had higher than expected requirements of opioid. And then despite the 80 micrograms of sufentanil and despite this 10 milligrams of morphine, it was extubation in the operation room with a very, very short, you see, time interval between the morphine and the extubation. So once you extubate the patient, you would have this increases in NOL. You should not react to this. You should actually respect them, and then they usually go down. And what you do now is evaluate the patient who is going to be able to tell you whether or not he would be painful. So it's clear is that the NOL, if you see the whole tracing, is much more sensitive than what happens with heart rate and blood pressure. And this is the trend in blood pressure and in the lower panel and in the heart rate. So it's absolutely evident that in some situations, the NOL, the blood pressure and the heart rate can be consistent and they go all in the same direction, but in many situations they do not. And the second issue is that the way the NOL was designed is that the amplitude in changes is much more important when you have an imbalance between nociception and anti-nociception, and in this respect, the heart rate probably, actually the changes, the amplitude of the changes in heart rate are much lower. So in this respect, the NOL is much more sensitive. The blood pressure is confounded by many issues. So in this patient, he was given, because of the hemodynamic instability, a continuous infusion of low concentration norepinephrine, and because of the low DPDT that I showed you on the Edwards monitor, this patient also received the dobutamine, low dose dobutamine. And there were many manipulations of the abdominal cavity, which actually confounded the blood pressure and the stroke volume. And therefore, it's absolutely mandatory to look separately at different components of anesthesia and anesthesia tolerance. So when you took the whole picture of the patient, basically in 80% of the time, the NOL was in the target range. And I showed you that the duration where it was out of the target range, the intensity was quite short duration, sorry, and the amplitude was quite short. So basically, if you look retrospectively at this case, in my mind, it is quite satisfactory in terms of what the NOL was supposed to do, that is achieve the best control of the nociception and the anti-nociception balance. And this is 20% unsatisfactory behavior actually concerns short durations, where we understood, and in half of them we decided to accept them because what were the goals were in terms of hemodynamic stability. So could we a posteriori done something differently to have a better control of the nociception and anti-nociception balance? Probably a faster pharmacokinetics with remifentanil could have helped. So the NOL in the context of a complex monitoring for a complex patient, I have no doubt that the NOL explores the nociception, anti-nociception balance much better, faster, more sensitive, higher amplitude than heart rate, MAP, or EEG, and you have seen the discordances, and therefore it brings complementary information, and the interbenching variability can only be detected with dedicated tools. So the requirements of this patient are quite different from many other patients, and because of the hemodynamic instability, we have to bring the thing. So if I come from what the NOL brought me for this complex patient, personalized opioid dosing, there's no doubt, and safer analgesia in a high-risk patient. And of course, those were the two main benefits of NOL in this complex case. So just to summarize with you now how you should reason in general. So basically, you have the nociception, anti-nociception balance monitors, you have the numerical EEG, and you have the MAP and the heart rate. And you have basically confounding hemodynamic factors. You have the pharmacology and hypnotic opioid interactions, the timing, of course, the PK/PD modeling is interesting, and you also have the opioid-free cocktails, and you have the nociceptive stimulation and the clinical signs. And you need to put all this into perspective. So if you put the numerical values, so we said NOL should stay between 10 and 25, the BIS should stay between 45 and 60, and the MAP and heart rate should not go beyond 20% plus minus changes. So there are clearly situations where they all go into the same direction. This exists, there's absolutely no doubt. And it is my impression, but I don't have the data, that this occurs mainly during the induction and the incision phase. There are situations, of course, where, let's say, it looks like the arterial pressure and heart rate are within the range. The BIS is low and the NOL is high. So this is actually shows you that you have too much hypnotic, not enough anti-nociception, and therefore you should actually choose different choices to bring those values back to what your targets are. There are also situations where the NOL is down, so you have an excess of anti-nociception, and the EEG is high, so they're clearly separated. And just to show you that we published an algorithm in 2003, this was, in my mind, the first algorithm that was ever published, and basically a fairly complex, which we simplified subsequently, you will see it. Basically, you need to take into consideration all the factors. The map, as usual, the nociceptive stimulation present or absent. You need to have a knowledge on what is your concentration of hypnotic and opioid. And the ideal situation is where everything looks fine. The NOL is in the norm, the map is in the norm, and the EEG BIS is in the norm. And this probably occurs in less than 50% of the patients. And you have all the combinations that are possible in outside of the ideal situation. And basically you need to look specifically at the discordances between the EEG, the hypnotic, the opioid, and the NOL. So to simplify for the, and look specifically at the NOL, so what we see here is, so the map actually is out of range. So we have an increase in map. If you use the EEG, the EEG is in the range that you expect, the heart rate would increase. And in this case, you look at the NOL. So we have an hypotension and tachycardia. If the NOL is higher than 25, you look at unplanned stimuli, distended bladder, the misplaced trocar, hyperextended limb. So you should consider to increase the opioid dose or to look at a specific excessive nociceptive stimulus that you can avoid. If the NOL is less than 25, probably the cause of the increased mean arterial pressure is not a lack of opioid or an anti-nociceptive, and is probably a vascular reaction, and you need to give a vasodilator. And if the NOL is lower than 10, of course, you should not give, even less than in the previous case, no lower than 25, an opioid or an anti-nociceptive, but look specifically at the treatment of heart rate and mean arterial pressure, and find a reason why NOL is lower than 10. Now we have a different situation in which you have arterial hypotension. So if arterial hypotension is present, then you have the situation where NOL is below 10. You may have an excess of opioids. Well, if you've injected sufentanil, then in this case, it will take time before sufentanil eliminates. If you're using a remifentanil, well, the pharmacokinetics is much more favorable, and you are going to be able to decrease the remifentanil concentration. But in any way, you should avoid injecting more opioids if you're using bolus of sufentanil or fentanyl. If the NOL is lower than 25, one should correct the hemodynamic abnormalities. And if the NOL is much, much higher than 25, well, in this case, you have to evaluate what is the reason of the arterial hypertension, and not hesitate to give opioids or an anti-nociceptive despite the fact that your arterial blood pressure is low. So once again, it's discordance between the different types of information. You can look at the effectiveness of regional block, and if you're doing let's say a tab block before the incision, and if the NOL is high, well, that means that your regional block is not working, and then you need to complete its and correct its ineffectiveness, stop the nociceptive stimulus, and reconsider despite your regional anesthesia to give additional opioid or an anti-nociceptive other than an opioid. And if the NOL is below 10, of course, you need to use the lowest possible concentration of opioid, because that means that your regional block is effective. And now you have the situation where you have an acute increase in NOL beyond 50. The map can still be stable. It can be actually delayed because you're measuring only every 5 minutes. If the patient is beta blocked, your heart rate will not go up. And so the only information is that the NOL is above 50. You should interpret this into the clinical context, but it clearly tells you that you have excessive nociception given the level of anti-nociceptive that you are having. And in this case, given the clinical context, you can either choose to correct it or wait for a few 1 or 2 minutes. But if it's prolonged more than 5 minutes, I mean, there's absolutely no doubt that you should correct it and take this into account. And in the opioid-free anesthesia, if your NOL is below 25, then it's something probably in the cocktail that you're using for opioid-free anesthesia in excess, and it confirms the effectiveness. So we're now having quite a good experience with continuous lidocaine. And I can tell you in many patients, but not in all, the usual lidocaine doses that we give actually put the NOLs systematically below 25 during the whole duration of anesthesia. And on the opposite, if the NOL value is much higher than 25, even if you go for opioid-free anesthesia, you don't have to hesitate to modify your cocktail. And what worked quite nicely, ketamine in small boluses is able to do just as well as the opioids. You still stick to opioid-free or opioid-sparing anesthesia. And in this case, basically, it's the right way to do it. So take-home messages to allow 15 minutes for interaction. There are many challenges in colorectal surgery. Some of them are universal. You want to go for ERAS. ERAS implies that you balance between lack of pain in the post-op, immediate post-op period, and also the possibility to be able to recover bowel function. So some of the goals in ERAS are contradictory, and finding the right balance between avoiding excessive pain and avoiding excessive dysfunction of a bowel comes with a personalized and adapted dosing of opioids or anti-nociceptive in opioid-free and opioid-sparing anesthesia. And so in ERAS, some of these contradictory goals actually can only be solved by using personalized monitoring and personalized dosing. And at times you have competing challenges, and I don't see how you can find balance without using the monitors. And you can use the patient's comorbidities, as in the case that I presented with the hemodynamic instability being a challenge. And in this case, it becomes even more complex. I bet that the nociception, anti-nociception balance monitors are probably here to stay. The literature, it's not me saying it, but the literature consistently has shown that the NOL has the best sensitivity and specificity. And I consider that multimodality in the NOL is a clear advantage, and the number of situations where the NOL would not work because of patient-related comorbidities is lower than in those in other monitors. The sophistication of the monitors in anesthesia, in order to be able to say that the anesthesia is adequate, so this sophistication is increasing. What level of sophistication can we accept? I don't know yet. Probably we need at some point in time putting information together, and such sophistication can be solved. And why am I so confident? That this is the most astonishing achievement of artificial intelligence, where artificial intelligence actually is being able to be better than 6 poker players. This is a very complex game where uncertainty is a major issue, and I'm convinced that in the future years, we'll get the help from artificial intelligence to be able to put together so much information. Thank you very much for your attention. And I'm open to and ready to answer questions.
Thank you for a wonderful presentation. I suggest that we start with the poll results, if Joella can bring them up for everybody to be able to see, and then perhaps you could comment on the results.
So the polls that we have, so not many voters, but still, so avoidance of intra-anesthetic arterial hypertension is not one of your goals. Well, you were only partly right, because there's credible evidence that intra-arterial hypertension is associated with many complications. So it becomes clearly a goal in managing anesthesia because it's associated with mortality and fairly short durations of hypotension, mild hypotension, that's palm mean arterial pressure lower than 65 for 15 minutes cumulative, is associated with mortality. You're fully right into putting the avoidance of post-op pain as a goal, and then one needs to find the balances. The fast bowel function, well, ERAS is based on fast bowel function recovery. Okay, so once again, it is an incentive to use as low opioid as possible. And if you go for opioid sparing or opioid free anesthesia, then you need to be sure that during this surgery and anesthesia, you're managing anti-nociception correctly. Decreased post-op complication, well, it's not of concern. It should be a shortened post-op length of stay. Once again, it's part of ERAS and it's medico-economically interesting. So I kind of disagree with the results of the poll, in which the voters underestimate a few elements of the way anesthesia is being managed. Can we go for the next results, please? And I thank Joanna. So heart rate changes. This reflects, I thank you for your sincerity, because this is what happens. So the heart rate changes is still used by many of us, but it's been reliably shown in very well conducted clinical studies that is neither sensitive nor specific. So we stick to what we have routinely, but be convinced that it's unsatisfactory. And it's similar for arterial blood pressure changes. So they're neither sensitive nor specific, but they reflect the clinical reality. And actually, it's an incentive for those who promote the use of dedicated nociception, anti-nociception monitors to go and actually improve the education so that we use those monitors a little bit more. So the EEG-based depth of anesthesia monitors, including the BIS, you can use them. Yes, so they provide information. The problem is that most of what you're here using, once the patient is paralyzed, of course, you lose any information based on patient movement. There's clearly in the literature, and in my experience, it's much more sensitive, those nociception, anti-nociception monitors, than heart rate, blood pressure, and the cortical EEG monitors. So once again, it shows that these dedicated monitors need to get the place they deserve, in my opinion. And the last, meanwhile, thank you, Joella, for doing this excellent job. So what worries you most? Single, patient experiencing postoperative pain. Okay, it's a concern for all of us, and it shows you exactly what the challenges of ERAS are, because you need to find the right balance between avoiding post-op pain and giving too much opioid to avoid post-op pain, and therefore actually alter the possibility of accelerated recovery because the patient would be too sleepy. And this is exactly what those monitors are supposed to do, is to find the balance between competing challenges. Thank you, Joella, again, for doing this in real time, and thank the voters for their involvement. So if there are questions, I would be ready to answer them.
Yes, absolutely. So we have some questions from the audience here. The first question here is from Sean about the use of remifentanil. So if remifentanil is used as part of maintenance and the NOL index is low, how can you know how good your immediate post-operative analgesia will be?
So you can, of course, you cannot predict this, because then the way you manage post-op analgesia with remifentanil is quite different. So if we have redone the case that I have explored, we would have used low remifentanil, activate then the epidural 30 minutes before the expected end of the surgery. We did not choose this option because we were afraid of hypotension in this patient who was hemodynamically unstable. So basically, you cannot make any presumptions with remifentanil based on your intra-op nociception, anti-nociception balance that is going to be quite optimized, what you need to do is to anticipate the end of remifentanil, okay? And then you need to therefore have a new plan, totally new plan for post-op analgesia. You have an epidural which works in place, then it's okay. You don't have an epidural, you need to go for morphine. So you cannot ask this monitor to answer questions to which it cannot, it will not predict something, okay? And this is specific with remifentanil because the elimination half-life is very, very short, less than 10 minutes, whatever the duration of infusion.
Great. The next question we have is around the use of NOL in intestinal failure patients with chronic pain. So have you had experience using the monitor with patients with chronic pain or patients who are opioid tolerant? The expectation is that these patients would be probably good candidates, really in need of personalized analgesia. So could you share your experiences with that?
Yes. If you don't have the NOL, what you would suppose is that those patients are tolerant and their intraop requirements are going to be much higher. And also because you expect that they are tolerant, you would tend to be more active on non-opioids, lidocaine, magnesium, ketamine, because it's anti-NMDA, etc., or eventually alpha-2 agonist. You will be surprised at how different patients who get the label chronic opioid treatment can be during anesthesia and surgery. Some of them will have high requirements. Some of them will have very low requirements. This is the most impressive element based on NOL monitoring. So once again, in my mind as a clinician, being with the EEG or being with the NOL monitoring, the main challenge is being able to adapt to the interpatient variability and at times to the intra-patient variability, okay? Once you have done this, then the questions, do patients who are on chronic opioid treatment or patients who have chronic pain without chronic opioid treatment becomes actually less important than I know, whatever the situation, I know that I can adapt to the interpatient variability, okay? So in theory, they would have higher requirements. Some patients do, some do not, okay? And only adaptive monitoring can show this.
Okay, we have another question here about the use of monitoring, the use of NOL in intraoperative trials under general anesthesia. Do you think that NOL should be integrated more often in trials, intraoperative trials?
I would say so. There are a few innovative approaches. I didn't go through them because I consider that the challenge is now to integrate the NOL into the clinical practice. I showed you two isobolograms of interactions. One is during induction and intubation, and the second is during the maintenance. There are a few groups who actually want not to be reactive, as I showed you, so the NOL goes up and I react. They want to be proactive and do calibration. So you take a patient, you put the patient asleep, the BIS is where you want it to be, and then you do a tetanic stimulation. So this is a standardized in duration and intensity stimulus. And then you can play around with the remifentanil concentration to see for that given patient, what is the remifentanil concentration that will allow you an increase in NOL for this specific intensity of and duration of the nociceptive stimulus. I think the next step in personalized medicine is to be able to find, at least for in the induction, but then you will have to repeat the same calibration procedure with the tetanic stimulation during maintenance, because I'm fully convinced that the encoding doesn't come from an intensity of the nociceptive stimulation. The encoding comes from the changes in the level of nociceptive stimulation. So once everything is in place, the incision, the trocars, whatsoever, once it's in place, then the level of nociceptive stimulation is stable, and then encoding will not occur. So if you want to introduce it into the clinical trials, then you need, if you want to compare things, drug A versus drug B, and opioid is a confounding, then I would say you need to have similar levels of NOL, because otherwise the confounding and the hypnotic opioid interactions are such that you need to put the anti-nociception at the same level. And if you're using something else than opioids to get the anti-nociception, then it becomes absolutely mandatory when you compare different interventions to be sure that your anti-nociception level is similar. And this can only be based on the NOL.
But all in all, I think that you are saying that if we administer a tetanic stimulus to a patient after induction, it could be that we will be able to anticipate whether this patient is going to be particularly sensitive or have a particularly blunted response to the nociceptive responses that will be occurring during the surgery. And this could also perhaps help clinicians be able to better personalize analgesia. Would you agree with that?
Fully agree. My only reservation is that this has been published for the moment. I've reviewed some of the papers who are actually going to be published. This has been done only during the induction period, which will include the incision. I'm fully convinced, based on clinical data and on pharmacology, on personal experience, that we need to recalibrate during maintenance, and probably a patient who looks like having high requirements during induction and intubation and incision, you have to review the process, because the same patient may have lower requirements during the maintenance phase. So I would say yes, for calibration is going to be but one should not extrapolate what happens in terms of requirements during the induction, intubation, incision to what happens during maintenance. This is my only reservation.
It'll be interesting to see as the knowledge around this develops and evolves. Another question, this lecture has focused, and our discussion has focused on the use of NOL in the operating room. But where do you see the use of NOL in other clinical environments? What would be the next clinical environment clinical setting in which you think that NOL could be helpful and benefit our patients? ICU,
clearly. And now my only question is whether what we've seen with the COVID, where all the patients or nearly all the patients who were intubated were being paralyzed, okay? And then once they get out of paralysis, you ask yourself questions on their level of nociception encoding or their level of too high anti-nociceptive drugs, and then with the consequences on hemodynamic instability. So clearly there's a whole field of investigation to put the NOL into the ICU, both in intubated, sedated patients, and probably we'll see in sedated, non-intubated patients. So I think this field is going to be huge and extremely interesting. But if you compare what we're doing in anesthesia, EEG, anti-nociception balance monitors, the ICUs, even the best ICUs, lag 20 years behind. So it is obvious to me that the next field and the next frontier, next border is going to be ICU. Lots to do on this exciting journey. So I'd like to thank you, Professor Longrois, for a fascinating presentation. And I'd also like to thank everyone, all the audience, everybody who has joined us. We have recorded this session. It's going to be available online for you to be able to review again. And we look forward to staying in contact with you. So thank you very much, everybody, and have a wonderful evening.